Welcome to Thought Leadership for the New Normal, a conversation series with Sacred Heart University deans. This week we ask our guests, how will this crisis impact home health care, rehabilitation, and elder care? Join us now live from the campus of Sacred Heart University with your host, Randye Kaye.
Hello, I am Randye Kaye from WSHU and Sacred Heart University, and I welcome you to this conversation with Sacred Heart University deans and other experts on important topics. I want to welcome our guest today. We'll be talking about home health care and elder care, rehabilitation. Our first guest is the Dean of the College of Health Professions here at Sacred Heart. Welcome to Maura Iversen. And then we have the owner and co-founder of Professional Care Physical Therapy and Rehabilitation PC. They have locations in East Patchogue and Riverhead, New York. Welcome to George Ciresi. Welcome, George. And Jessica Dunn. And Jessica is a board-certified geriatric clinical specialist, also clinical director of Genesis Rehab Services. Welcome, everybody. Now, I have a bunch of questions to ask you. You know, I recently had a call from an elderly neighbor across the street, and she seems to be doing okay, and we're all looking out for our neighbors. And I asked her how she's doing, and she shared with me that she's really scared, that she was planning to sell her home and move into an assisted living, but she's had several friends who passed away from COVID, and now she's going to have home health care. And, you know, I find myself wondering on a personal basis what that means for her and also for the people who will provide that sort of care, either in facilities or at home. So, Dean Iversen, will begin with a conversation for you, a question for you, and George and Jessica, you feel free to chime in with any of these questions if you wish, but I have definitely questions directed for each of you. So, Dean Iversen, how has the pandemic impacted education for health professionals, the way we've delivered it?
It's impacted in a variety of ways. First of all, as you know, when the pandemic hit, we had to close down our on-site clinical skills training. As a result of that, we needed to identify new modes of delivery of education as well as innovative ways of providing instruction via technology for our students. We ended up doing a fair amount of videoing of clients, and luckily Sacred Heart has a very robust technology setup, and so we were able to rely on some resources that currently existed in order to augment our teaching instruction. Another piece was that during this period of time, a number of the health professions were actually not reimbursed for telehealth. And so that was not a component that was an integral part of their academic education. However, as the government realized the need for care delivery in the home, the policies actually changed with reimbursement, and as a result, we needed quickly to ramp up and get involved in the best ways of care delivery via telehealth. Obviously, there are things that can't be anticipated. For example, we've had one of our alums who's an occupational therapist who moved to telehealth when it became approved by the government, trying to work with families and children within the home. This particular woman, Julia Chapetta, actually works with young elementary school children. And not every home has IT resources. Not every home has materials that you need in order to provide care. There are also language translation issues that came into play. So finding online learning platforms like Bloom's Learning took a while for the therapist to kind of scale up, adapt those, and then implement them in the home. The other is many family members were not as comfortable or not knowledgeable about what the child was doing at school during the day. And so that was a big transition. For our elders, as you mentioned, you know, there was a lot of fear about receiving care in institutions. And so what happened was a lot of elective surgeries were postponed, or those that would have normally gone to a rehab setting actually came home. And so the acuity level of patients was very, very high. And many of the home care institutions, for example, developed a COVID kit, so a kit that was for family members as well as a kit that was available for the healthcare providers going into the home. But even just donning and doffing, meaning taking on and off your PPE, is different in a home setting. You're doing it in a garage, you're doing it out in a hallway, you're doing it in many different areas where it's not the same as a hospital that has a more natural setup for that. So a number of home health agencies set up buddy systems to mentor people and provide feedback on proper donning and doffing. Leaving a PPE kit in the home was another way of ensuring that there was safety both for the elder at home and for their caregivers. And I think one of the main differences with this pandemic is oftentimes those individuals in the home that could help the therapist with care could have been sick as well. And so now you have people needing to isolate and not being able to join in and help out. And I'm sure my colleagues will have some other thoughts about this, but those are my initial reactions.
COVID kit, that's PPE basically? Is that what you mean?
Yes.
Okay.
Yeah.
All right, thank you. Well, George, you are out in the field all the time, so by chiming in, let me add this question. Can you take us kind of like through a timeline? What a year it's been, of the events from early 2020 until now, and we've all had to make adjustments along the way. How have you had to adjust your business and your practice as these events unfolded?
Yeah, I tell you, it's been a roller coaster of a ride for the last several months, to say the least. As you mentioned, I own an outpatient orthopedic and sports physical therapy and occupational therapy practice out here on Long Island. We have locations in Patchogue, which is on the South Shore, and in Riverhead, which is a little further out east, but nonetheless still pretty close to New York City, which, as we all know, was the original epicenter of the COVID crisis. But to answer your question, I probably first started monitoring the virus probably back in early January. And I did it for two reasons. One, from a business perspective, but also from a personal perspective. My family and I were planning a cruise that was going to be leaving out of New York to go to down to the Caribbean in March. So, my wife and I were a little hesitant to start, but we made the decision that if the first reported case were to come to New York, we would definitely cancel the trip. And sure enough, March 1st, the first reported case came to New York. We canceled the trip. And that's when my partner, Jim, and I really sat down and started developing and implementing a plan for the practice in terms of safety, but also logistically in preparation for the worst case scenario. And ironically, as we all know, the worst case scenario happened. So initially it was simple. It was things like just implementing more sanitary processes, continuously monitoring the CDC and the state health department, which honestly was changing every single day. I think it was mid-March we first had our first staff meeting, and we started the meeting off by telling the staff that we allowed and encouraged any staff member who is not comfortable coming to work from home if feasible, to use their paid time off, or just to simply take a leave of absence. We really didn't want anyone coming to work that wasn't comfortable coming to work. And at that time, 3 of our 19 therapists chose that option, which was completely fine. Another thing, we discussed was it was our goal not to lay anybody off at that time. And one of the things I'm really most proud of is, we came together as a team and decided that we're not going to lay people off, but if we have to, we'll all decrease our hours accordingly to meet the patient demand. Another thing that we discussed was, is PT really essential? Some of us thought it was essential. Some of us thought maybe it wasn't essential. And it took a few days to get clarification from the governor's office with the help of the private practice section of the APTA to find out we were classified as an essential group of people. And then lastly, like Dean Iversen was saying, we were exploring telehealth options. In New York at that time, telehealth wasn't an option, but there were rumors that was going to change and that some insurance companies were going to follow suit. I think it was late March when the first patient gave us a call and said that they tested positive, which created a logistical nightmare for staffing, because back then we as clinicians were wearing face masks, N95 masks, but the patients weren't. So as per the CDC, we then had to quarantine any staff member that was in a close proximity to the patient that tested positive. So it was, I almost felt like a hockey coach at one point where, 2 or 3 therapists would go into quarantine and 2 or 3 therapists would come back. Unfortunately, at that point, probably in early April, our caseload decreased to about 50% of the pre-COVID level. And unfortunately, at that point, we had to make the tough decision to start laying people off. Fortunately, that was right after the federal government announced that they would add the extra $600 per week in unemployment benefits. We continued a downward spiral to probably about mid-April. We hit rock bottom. We were about 25% capacity. And just to put it in perspective, we used to see almost 1,400 patient visits per week, and we were down to about 350. We went from 70 employees down to about 25. And not to mention this whole time, and this could be a whole other conversation, we were navigating the whole PPP, the Paycheck Protection Program situation, which was a whole nother nightmare. Then I'd say May, we pretty much weathered the storm. We were at rock bottom for a good month. We came up to June in New York, in my region. Elective surgeries were allowed to begin again on June 6th. Shortly thereafter, we saw an increase in referrals. And that brings us to this week. We're currently at about 65% of where we were previously. We're up to about 40 employees, and our goal has remained unchanged of really trying to get everyone back as soon as possible. So yeah, it's been a roller coaster to say the least.
Wow, thank you. And if anybody is watching in an area outside of where we are, again, we are located in Connecticut and Long Island in New York. And so at the moment, our numbers are pretty good. And so things are coming back, but it may be a very different story in other areas of the country and of the world, of course. Jessica, let me bring you in and ask your perspective on this. And also, George mentioned telehealth. So let's talk about telehealth too. How has the pandemic impacted your perception, therapist's perception of telehealth in this post-acute environment? Are you muted? Hey, Jessica, we are having problems hearing you, so I'm going to go back to Dean Iversen for a second. Work this out. Okay. Wait.
Feedback.
Try again. No, so perhaps.
There's too much background noise causing her mic to go out.
Okay, we think there's too much background noise causing your mic to go out. So I don't know if there is any background noise where you are, or if perhaps.
Let's just go on.
I have producers over here. I'm going to ask, should she leave and come back to the call?
We can try to do that.
We can try to leave and.
Actually, you know what? Let's not do that. No, 'cause it's
No.
gonna miss- yeah. So
Don't do that.
Let's go back to Dean Iversen and tell her we're
Can she mute again and unmute?
Can you mute and unmute one more time? Mute your mic and then unmute your mic, and we'll see if that does some kind of magic. I hear something.
we hear her on our computer.
We hear you on your computer, but we don't hear you speaking. Apologies if you're watching.
Let's just go somewhere.
We will work this out. So Jessica, I'm going to
Move
on, and hopefully we'll, let me go back to you, Dean Iversen. In what ways, let's talk about the delivery of home health care. How has the pandemic changed the way home care is delivered?
Well, I think one of the things that has been very important and critical for protection of patients is the fact that many home health agencies developed a COVID team. So there were a group of individuals that trained together, developed their competencies together, or as I said, around donning and doffing, PPE, but also thinking about like transitioning or transmitting infection from home to home, so using shoe coverings, which you normally wouldn't do. I think that it has positive effects in the sense that care providers in the home, nursing, PT, OT, speech, have really come together as a group. I think they have a better understanding of their skills and contributions to home care, so that's quite good. Acuity really is quite high for those patients that do come home that have been infected with COVID. It's not just typical deconditioning. They are really quite weak when they're coming back to the home, so the amount of care that they need is quite significant. In talking with one of our alums most recently, who is involved in home care delivery, particularly with the elderly, one of the big concerns with home care is the patient too sick to come home and receive home care? And in some of those instances, the patient has been able to stay at home, but first to have 24-hour care around the clock and then have rehab services come in. So care delivery in the home 24/7 and then rehab coming to augment it has been the way that patients have been able to stay at home, particularly those that are worried about going into rehab or skilled facilities. I think another major aspect of this is recognizing that with this particular disease, it's a very complex disease. As George had mentioned, when we began, we had an understanding of a constellation of symptoms that were relatively small. And as we learned more about the disease, the case definition, or the way that we describe the symptoms of the disease, really evolved. And so it's something that therapists and care providers need to stay abreast of on a day-to-day basis. And I think that's something that we need to keep in mind moving forward, that things will always be changing, and it's important to always be monitoring what's going on from the CDC and how the state and other agencies are helping provide recommendations for care.
I think ever-changing. Many people have described it as whack-a-mole. It's just it's an ever-morphing situation. George, can you chime in on that at all? Because I will be asking you about new procedures, but anything to add to this conversation with what Dean Iversen just said?
Yeah, I think she nailed it. It's ever changing. It really is. And, I speak to a lot of colleagues in the field, down in Florida, up in Massachusetts, and we're kind of all sharing information, which is great, but it's ever changing. If you remember in the beginning, the CDC was, only encouraging healthcare providers to wear masks and not the general public. So I think you have to stay dialed in to what's going on, the change in symptoms. They've added a few new symptoms of the disease, as Dr. Iversen just mentioned. So yeah, there's a lot of great resources. New York State, for us, where I live, Department of Health. Even, another great resource we had out here in Suffolk County was the Suffolk County Office of Emergency Management, which was instrumental in us getting a lot of that PPP early on where we couldn't find it. And, that was something that really helped us out in the beginning, being able to give patients the masks, which they didn't have when they first were coming into our office.
Okay, thank you. While I have you, are there new procedures that you have added to your practice? Because we want to improve the safety of the patients, we want to improve the safety of the staff, and we keep learning more and more. Any new procedures that you've added?
Yeah, there might be one or two that we've added. No, but seriously, yes, we've added a lot. I had the conversation with the staff and continue to have the conversation with our staff about safety, number one, and optics. It's important that we have to be safe, but we also have to look safe. We want patients to feel comfortable coming into our office knowing that we're taking all the precautions. And whether that means wiping down treatment tables between every use, even if it has to be done twice as the patient walks back so they know that the equipment was wiped down. We allocate one physical therapy aide 4 times a day to go through the whole entire office and clean everything, every door handle, the front desk, the waiting room, every piece of equipment. We actually instituted right in the beginning, we performed temporal scanning thermometer checks on every patient and staff as they entered the building. And what I find interesting is that we probably did about 10,000 temperature checks, and would you believe not one person came to the office with a fever, which tells me that the general public really gets it and understands that if they're not feeling well, they should be staying home and getting medical attention. Even in the beginning, we had questionnaires about their travel history, educating them on their symptoms, asking patients to come alone, or if they're driven to the office, have their driver wait in the car, separating treatment tables, socially distancing. In our Patchogue office, it's pretty easy. We have a pretty large office. It's about 7,000 square feet, but in our Riverhead office, it's significantly smaller. So we had to adjust the schedule to allow less people in the office at the same time. And like I mentioned earlier, prior to masks being mandated, through the help of the Suffolk County Office of Emergency Management, we were able to get a lot of the PPE to give to the patients as they would come in, which really was a game changer. Like I mentioned earlier, because if a patient was wearing a mask and a therapist was wearing a mask, and if unfortunately the patient tested positive, the therapist then would not have to be quarantined. It would be categorized as a low risk category. So that really was a game changer in allocating staff. Of course, things like providing protective eye equipment for the clinical staff, and doing what I think physical therapists do best, really simply educating our patients on the symptoms, the risks, the safety precautions that they can take, which in turn will keep us safe, it'll keep them safe, and it'll keep the rest of our patients safe. Two more things that we're doing right now, we're exploring weekly COVID testing for the staff, which will keep us ahead of the curve in case somebody does, test positive. And also, we're creating an outdoor exercise space for our fitness and athletic performance clients. Because right now in New York, technically today was the start of phase 4, but gyms aren't allowed to open unless they're outside. So we're actually having that built as we speak. So yeah, there's been a few things that we've done to try to mitigate the risk. Did you lose me? Did you lose me?
I can still hear you. I don't know if we're on calls.
Can we try to bring Jessica in? Is Jessica hearable? Not yet. No, we cannot hear you. So I wish that there was a way to get you to answer things. Not leaving and coming back. Should we try it?
I'm gonna see if we can, I'll see if she can call
Can we have her try to call in?
Okay, we're gonna have to. All right. So I'm gonna hold your questions until perhaps you can call in on the producer's cell phone. So I'll move on to Dean Iversen. What do you think? Everything changes. What do you think will be the new norm for home care? Let's talk about preparing the students. How can we best prepare our students to meet these new needs of home care?
Well, one of the ways that we can certainly do that is by simulating the home care setting. So we at Sacred Heart actually have a home care suite. It is a typical apartment. There's no hospital bed. It's a regular bed, a regular wash shower, a functioning kitchen. And the students will now have an opportunity to practice, for example, squeezing into a small hallway and trying to get their PPE on and off in the proper manner. We're having all of our students go through protocol and be trained before they can even walk on campus to come back to practice their clinical skills, which they began back in June 8th under Phase 1B in Connecticut. I also think we are spending a lot of time and effort exploring the different telehealth platforms, both for younger children at home as well as for individuals at home that are older adults or middle schoolers. Certainly, there are two of our speech therapists that have identified some really significant issues when you're working with children that have stuttering. How do you help to communicate with them when you're working in telehealth is really challenging. And so it has really opened a lot of interesting ways for us to explore how to communicate with people with different abilities. Communicating online, as we know, or through video, which I thought was really fun in the beginning. I'm not really feeling that after a while. It changes the way that you communicate. You need to be a lot more creative when you're working through telehealth with your clients to create things that are A, available in their home, B, are engaging and keep individuals engaged. You're working with a middle schooler. Suddenly now mom and dad need to be there and be present, which not all middle schoolers are very thrilled about. And so how do you keep communication channels running? One way to do that, for example, is physical therapy or occupational therapy, to ask the parents to video the child doing the skill that you want them to do, and then to share that video with you. So you're kind of calling back in and communicating with the parent about how that individual is performing the exercise and giving feedback. So in some ways, it's great because with parents and children, it's a great way for them to interact and for the parent to see how much a child can and can't do. But in that sort of middle school age where parents are less cool and not fun to be around, you have to find a way to keep a child motivated and be engaged.
Thank you. Yeah, I think we're all finding workarounds, and in general, in a lot of these conversations, we find that we are gaining a new respect for things like telehealth and online learning and some of the things that maybe we didn't trust so much before, but now we've had to trust them, and we're discovering some really good new ways to learn and interact and diagnose and treat. But we all know there are certain things that cannot be done online. And so it's interesting to see home health care, not just elder care, but children and others that need rehab at home, how it is changing with regard to that. So I think that we are working on getting Jessica to come through on a cell phone, talk about workarounds. But meantime, let me go back to you, George, and talk about some of the challenges and the obstacles that continue to be present as we all try to move forward. You're rebuilding your practice, as you shared before. When do you think, hard to tell, I know, an ever-changing situation, when do you think you might rebuild to a somewhat, I say normal level, let's say the previous level, with these workarounds or without? Do you have a time frame? And what are the challenges or obstacles that you're facing as we work toward that?
Yeah, that's a great question. I think there's a lot of variables in that equation. Number one being, will there be a second wave? And if so, how will that affect our ability to get the rest of our employees off unemployment, which, like I said before, is really our number one goal right now? Can we get all of them back? My concern is that there still is going to be a percentage of patients who do not feel safe or simply don't want to come into a public space like a PT office, and that might limit our ability to get back to 100%. My goal right now is if we can get back to about 80 or 85% by the fall, I think I'd be happy. And as crazy as it might sound, I think it might be a solid year. I think it might be next February or March, and maybe that'll coincide with possibly a vaccine before we get back to 100%. But there's a lot of unanswered questions. What is this going to mean for the region, for other PT offices? What effect is this going to have on the job market? I think of a lot of new grads that just graduated that are looking for a job that are going to be competing with very capable, other maybe more experienced candidates. That's probably only going to drive the salary request down, which I don't think is good for our profession. Will other PT offices decide to work more efficiently? And what I mean by that is, are they going to hire less staff, both clinically and administratively? What effect is that going to have on patient care? Obviously, higher unemployment numbers means less people are going to have health insurance. There's going to be more people with less disposable income that, may question the value of that high copayment for PT 2 or 3 times a week. Like we talked about before, is telehealth going to be allowed going forward in New York? Right now it's allowed, and is it even a viable option? Is that something that we want to pursue for patients and for the business? People that know me, I'm the most optimistic person, so I think it's important to stay positive and focus what's unimportant. And right now, what's important is staying healthy. I know my staff, we're ready to work and overcome any challenge that lies ahead, and I'm confident that we can do that.
So much. So now we are going to attempt to talk to you, Jessica. I have a little cell phone right here, and hopefully it will work. Hello, we see you. So I had some questions for you. Can you hear me okay?
I can hear you perfect, Randye.
All right, good. All right, we have a thumbs up here. So can you, first of all, I hope I know you've been dealing with these technical issues, but I think you've been hearing some of your colleagues' answers to the questions. Let me ask you how this pandemic has impacted the therapist perception of, let's say, telehealth in the post-acute environment.
Well, yes. I'll try to answer the question, so hopefully you can all hear me now. I apologize for the technical challenges that we're having today, which is one of the things that as therapists we are really readily having to work through when we are using telehealth. But really the pandemic has really changed the landscape and has allowed us a huge opportunity to readily use telehealth, much more than we were in the past. And I actually have the privilege to be a delegate for the state of New Jersey for the APTA House of Delegates. And back in 2019, our sister state, New York, the New York delegation actually actually created an RC for the House of Delegates. It was RC 41 that charged the APTA to develop best practice strategies to guide the use of telehealth in physical therapist practice. And it was really interesting because when this RC was introduced just in 2019, so really less than a year ago, the conversation around telehealth was really focused more related to ethics. And it was related to, as a profession, would we be able to offer the same level of standard of practice if we provided services via this mode? And so the conversation really was really focused on the barriers rather than increasing access to services or how telehealth may be an adjunctive service to enhance the efficacy of our services. And then the pandemic happened, right? So the Northeast was really impacted very badly. And very quickly, within a few weeks, we saw centers that were COVID naive were now COVID positive. We were really struggling with not only a number of patients being COVID positive, but our staff. So many of our staff were now positive, and we really were having to look at resource management very differently, our provision of care very differently, and we really had to very quickly, figure out how are we going to service our patients and make sure that they don't continue to decline or develop other secondary impairments related to social isolation and or physical inactivity if we don't stay involved. And so the conversation switched really there. So really March into April, we saw the conversation amongst rehab professionals change from barriers to really opportunities, and how this mode was really necessary to provide older adults therapy services in the post-acute setting. And then as Dr. Iversen and my other colleague George had mentioned, that really we had some other barriers related to reimbursement, and Medicare came out with waiver 1135, which in March didn't necessarily include therapy professionals in the post-acute setting, but on April 30th, another additional provision did. And so at a federal level, it really said for Medicare that therapy professionals would be reimbursed for providing telehealth services, which was a huge opportunity for many of us and for access to care and for our patients. Now, that was just one provision. So when we talk about telehealth, there's lots of rules that we need to follow. So in addition to federal guidelines, there's also State Practice Act guidelines related to telehealth. And there's a lot of states that right now, while they are functioning in a public health emergency, have also included therapy professionals as part of their team to provide services to older adults, which is a very powerful thing. And then we also have reimbursement and payer guidelines. So I think that beyond the perception of therapists, which has really changed in a much more positive light, I think as a country, people are really starting to understand how this mode can really impact people's access to care as well as the level of services that they're receiving. So I think this has been a huge change for us in a very positive direction.
Thank you. I mean, it's certainly been a crash course for so many of us in so many things. And although some of us are taking a breath, we're all pretty much still in crisis mode. And as George was saying, it might take a full year for things to settle in, and then maybe another year after that for us to see how the dust settles and what impact it has had, both positive and negative, on the job market, on the training that we receive, on new modes of care that we discover work and how to combine those. We've got a whole lot of things ahead. But while I have you and we can hear you, how do you think this is going to impact? And of course, George and Dr. Iversen, feel free to chime in on any of these things in reaction. But how do you think this will impact how rehab professionals and medical professionals will be trained? What factors do you think, we're still learning, obviously, that will have to be considered?
Yeah, I think that's a great question, Randye. And so in my role with Genesis Rehab is part of my title is University Relations Director, and I've been in this role since 2009. And so part of my role is to really support our student programs. So not just physical therapy, but occupational therapy and speech language pathology training, graduate level training in the post-acute environment. And I cover a very large geography. And so, I have the opportunity to work with a number of programs and, a number of students, and certainly on the forefront of many individuals, so many universities as well as therapists, is how are we going to allow students back into our centers? And that's a really important piece, because we need to make sure that we're training the next generation and the next group of professionals on how to work with the older adult geriatric population. We need to ensure that they have the skills that they need to service this population. And so right now, obviously, because of infection control and infection related thoughts, that we are not allowing students in the centers. They're considered non-essential volunteers and or personnel. And so until actually the nursing home is in phase 3 of the recovery, we're not really supposed to have students back into the center. And so we are looking at a number of factors related to this. So we're looking at state testing requirements. We're looking at the phase of reopening that each state is in. We're having to consider not just, federal guidelines, state guidelines, but down to the municipality and local, authority guidelines related to certain geographies, as well as looking at community spread. We're looking at certain states have state quarantine guidelines. So if you're traveling out of state and you're entering into a state and you're from somewhere else, there are certain guidelines related to quarantining for 14 days before you're really supposed to be out and about within that state. And so we're looking at a number of these factors. In addition to students directly, we're looking at, PPE, the use of PPE, how having students and another person in the center and using PPE might impact, our supplies, as well as making sure that students have the proper training to don PPE, doff PPE, and that they also have additional education and training and support related to COVID. Because as we mentioned before, this is not just a respiratory virus. This virus impacts, our endothelial cells, it impacts the heart, it impacts many different organs. And so we want to make sure that our students entering into our centers are really prepared, that they feel comfortable, and that they know really what to do as far as from an infection control and emergency procedures. And so these are all things that we're really readily looking at and really anxious to work through, because we recognize how important it is to train our therapy professionals.
Thank you so much.
Mind me joining in, Randye?
Go ahead. Yes.
Yep. In parallel to that, as I mentioned, all the points Jessica makes are very solid. We at Sacred Heart, we actually opened under phase 1B, following all of those guidelines for the state, as well as the CDC recommendation. So all of our students spend about 8 hours in COVID training. That means understanding the full pathophysiology of the disease, infection control, practicing donning and doffing PPE before they even walk in the building. We are having all of our students, when they do their clinical skills, they wear a mask as well as a face shield, because obviously touching a patient, you can't be 6 feet apart. So social distancing can appear when you're trying to draw blood, when you're trying to take a blood pressure, when you're trying to manipulate a spine. So in one way, our health profession students are really like the leaders among the university student group, because they understand fully at this point how important safety and of abiding by the guidelines, wearing PPE, and understanding proper hand washing technique. They understand that so much more than perhaps a student studying history or English. And they really are living in the moment right now. So my students have been on campus since June 8th, and they are continuing to practice all of their skills. We're even making a little pioneer promise, which is Sacred Heart has pioneers. So these students are making a pledge to protect one another and their community. And I think it will develop a sense of camaraderie. But our clinical ed team, working together with individuals like Jessica, can help to ensure that these students are really probably better trained than I was as a student with respect to PPE and understanding universal precautions. And I think that that is something that's really important that will help us to work through those complex things of some of our students are in Connecticut, but I'm from Massachusetts and are going to Mass, or maybe they won't be going to Arizona. That's a little bit of a hot spot right now, but to other areas in the state. But they're well versed and well prepared before they walk out the door. And I think that many health professions, colleges, and the country are embracing those same strategies and want to ensure and reinforce with our clinical colleagues that our students are prepared and ready to protect you, your clients, and the community at large.
That's wonderful. Thank you. And it brings to mind that we've been so caught up in the contagion of the disease, and we're still learning about the effects of the disease. So that's another thing. And thinking, Dean Iversen, about Sacred Heart students who may not come from Connecticut, who may be trained here and then go home to a state like Florida or Arizona, where they're going to use their skills in an even more intense environment. George, anything to add on this topic? Because the next question I have for really all three of you is what you think the new normal might look like. George, anything to add on this question, or you can just start with the new normal
I actually
question?
had a question for Jessica, because she obviously seems to be the expert more so than me on telehealth. Do you think from a reimbursement standpoint that telehealth is here to stay? Do you see the insurance companies following suit for good, or you think they're going to back off once this pandemic is over?
Was that question for me, George?
It is.
Okay.
Yes.
Okay. I thought I heard it. So, well, I might be able to better answer your question on July 27th, but because right now, the national emergency right now is through July 26th. So we're really readily anticipating that CMS is going to make some big decisions about telehealth, but it does look like Seema Verma, who is the administrator for CMS, is very much on board with extending these waivers beyond the national public emergency. So I have a feeling we're going to see this to stay. I know that 35 senators this week wrote a letter to Congress really advocating for telehealth and really advocating and to push us moving forward, because this has definitely opened the door for us as providers, as healthcare professionals and providers. And I think people are really recognizing how much we can really support public health initiatives as well as prevent debility and have a big impact on patients' recovery and mortality rates. So I think this is going to be the door. This is the door to keep us on this trajectory forward. So maybe talk to me on July 27th, and we'll see if I might be right. I don't know.
A reminder, by the way, if you're watching us live right now, that you are welcome to post your own questions in the comments box, and we might have a chance to get to it. And thank you for watching. You can always view it later as well. My final question is for all of you, but I'll start with you, Jessica, since I have the cell phone up to the microphone. What do you think the new normal might be in rehab?
Well,
take a guess.
That's a big question, but I think that what this has definitely taught us is that we do need to be much more mindful about our infection control protocols. And I think that beyond just COVID, I think that particularly in the inpatient post-acute sector, what I've at least observed is that as we moved through this pandemic, we got much better about quarantining individuals, about monitoring people, patients' vital sign responses and health status, and that we really got better about our infection control protocols within the center and adhering to those protocols. And really quickly, we saw centers that in the beginning of the pandemic, it was very difficult to control the spread of COVID, by really April, we were able to quarantine units off, and we really were able to localize that the virus into a certain group of patients, and we're much better about the management of that. And that has a lot to do with testing, obviously, I think. So I think that really has set the stage for really better infection control protocols related to other types of organisms like VRE and MRSA and staph. And I think I would hope that those protocols are going to be here to stay for quite some time. I think that's the biggest impact as far as the new normal that I see related to that and PPE.
Thank you, Jessica. George, I'll bring it to you. What does the new normal look like for you?
Yeah, I tend to agree. I think we've learned a lot out of this whole pandemic, from infection control, number one, but also, how to run a business, making sure that you have funds that are allocated in case of emergencies. Like I said before, I'm a pretty optimistic person, and I learned a lot personally. I learned a lot from my employees. You see the sacrifice that a lot of people made, and you remember what brings us together is, our love for one another, and the ability to work well as a team. And I think it just gives me the strength to know that we can overcome anything, and whatever the new normal is, I think we can hit it head on and overcome it.
And I would just add to that.
Go ahead. Yes, I was just going to get to you.
Well, that's all right. Thank you, Randye. One thing that I think has been an essential part of particularly physical therapy, but many of the health professions, is this importance of health promotion, not just disease prevention. And what COVID has shown us is that these patients are highly deconditioned, much more so than we anticipate for somebody that has typically a respiratory illness. And we know that it has now moved into the cardiovascular system, as Jess said, with the involvement of the epithelial lining. But we see such rampant changes across our country with respect to COVID. Younger kids having higher levels of obesity than we had in the past before, as a direct result of lack of activity, not going to school. We also see the mental health impact of people being isolated, both for the individual and for the family members that are experiencing that loss of not being able to engage with their loved ones. And so I think that care delivery is going to really look at a comprehensive, holistic view of of individuals, from mental health to health promotion, as well as to rehabilitation. And that full spectrum of care shows us as a group of health professions that we truly are essential. So in my mind, the initial debate about are we essential or not, and should students be coming back into the clinic, I think we're going to have a population in the U.S. that is much more deconditioned from being quarantined, from being isolated, from becoming depressed about being isolated. And we really will need to have this population of workers out in the workforce, but in a broader scope than we've seen in the past.
Thank you so much. So I think that brings us to an end. I want to thank all my guests for joining me today. I really appreciate it. I'm Randye Kaye from WSHU and Sacred Heart University. We have another topic and another episode coming on July 15th, and I certainly hope that you will join us. Thank you very much.
Thank you, Randye.
Thank you.
Thank you.